Thank you for the opportunity, Dr. Narula, and good evening, everyone. Thank you for joining this late evening session. My name is Lokesh Sharma. I head public health business for Africa, Middle East, and South Asia at IQVIA. First of all, Dr. Narula, big congratulations to you for organizing this wonderful session and bringing all of us together to share our views on a variety of topics.
Thank you very much. So if you allow, then Aishwarya can start the credentials, and then from there you can move.
Sure.
Aishwarya, over to you.
Yes, thank you, Narula sir. Thank you, Lokesh sir. Welcome one and all. I extend my warmest and hearty welcome to everyone who has joined for the annual Global Conference, 25th edition of Pradanya on the theme Digital Health, Sustainable Development and Wellbeing. Pradanya, as the meaning itself goes, has had a long journey of 24 years, spreading wisdom amongst young minds and professionals of domains like healthcare, hospital, pharmaceutical, and rural development sectors. It has served as a prominent platform of interaction between industry luminaries and a fresh talent pool of students. I am happy to share that more than 40 speakers from 11 countries are addressing the different sessions of this conference this year. Well, I am Dr. Aishwarya Shityalkar, and I feel privileged to welcome all the participants and delegates today on behalf of IIHMR University for the 3-day conference. After the grand inaugural session, let me have the privilege to walk you all to the first plenary session, where our agenda is a discussion pertaining to digital health, its opportunities, and the road ahead. Well, without further ado, I would like to welcome our distinguished speakers for the session, starting with Mr. Lokesh Sharma, who will be the session chair. Mr. Sharma is the Senior Principal and Practice Leader, Public Health at IQVIA. He has about 15 years of experience in research and consulting with an expertise in the government and public sector. His key focus areas are business development, solution designing, service delivery, project management, product development, and people management. We welcome you, sir. Moving on to our speakers for today's session, we have Dr. Rajiv Singh. Dr. Singh is the Director General at Indian Chamber of Commerce, Kolkata. He is an experienced professional with a demonstrated history of working in industry associations, private sector, and academics, and is highly skilled in policy analysis, governmental affairs, strategic planning, and event management. We welcome you, sir. Moving on, our second speaker is Dr. Rajiv Sharma, who is the founding director of Motorec Infotech Private Limited, Bengaluru. Dr. Sharma is a medicine doctor, an MBA, and a problem-solving entrepreneur who has been a co-founder of 2 successful international companies. He specializes in maximizing opportunities for corporations to facilitate income that is contributed to betterment of their financial positions in the domains of healthcare, clean energy, logistic and supply chain industries, spanning across different regions like India, Japan, Middle East, and Thailand. We welcome you, sir. Talking about a third speaker, we have Mr. Cody Hill, who is the Senior Project Manager and Consultant at Houston Methodist Global Health Services, Dubai. Mr. Hill leads project management, advisory, and analytical work supporting the Kingdom of Saudi Arabia's Vision Realization Office in Private Sector Participation Initiative. Also, Mr. Hill has more than 14 years of expertise in healthcare administration, project management, operations, revenue cycle management, and consulting. We welcome you, sir. Moving on, our fourth speaker is Dr. Seema Singh, who is a digital health business leader at Tata Medical and Diagnostics Delhi with an experience in working with and building new businesses in healthcare. She's a medical doctor and MBA with an overall experience of 15 years in business development, key account management, clinical medicine and protocol-based care, medical education and research. We welcome you, ma'am. Taking this forward, our fifth speaker is Mr. Anurag Saxena, who is the Principal and Head of Digital, Public Health, Government Solution for South Asia at IQVIA, Delhi. Mr. Saxena has an extensive experience in management consulting and has worked with Deloitte, Ernst & Young, etc. He has led some of the world's largest digital transformation projects in the areas of digital health, digital identity, digital government, and digital payments in advisory and program management roles, and has also worked across Europe, Africa, Middle East, and South Asia. We welcome you, sir. Coming to our last speaker for the session, Mr. Sagar Aloni, who is a business analyst at First Doctor, Mumbai. As a seasoned healthcare operations specialist, Mr. Aloni has an exposure to international as well as Indian healthcare system. Mr. Aloni is currently working with pioneers of non-surgical spine treatment and largest chain in India dedicated to physiotherapy for back pain at QI Spine Clinic. He is working to develop an AI-enabled smart application which will have capabilities to guide doctors with treatment suggestions and a complete plan of care for more than 250 back conditions. We welcome you, sir. With that being said, I would now like to hand over the session to Mr. Lokesh Sharma for the discussion on digital health, opportunities, and the road ahead. Over to you, sir.
Thank you, Aishwarya. And thank you also for reducing my effort to introduce everyone. So I think we've got our experts coming in from the spectrum of this sector, and it would be really, really great to learn from their perspective. I hope everyone's near ones, families are doing absolutely fine in the current COVID situation. We all have gone through, seen how this situation has for everyone across the class, specifically, for the poor, looking at issues around their livelihoods. And I think with this situation, or I would say the current pandemic has forced us to evolve, recognize, and come out with the stronger than ever kind of a situation. We have been seeing a lot of efforts to strengthen our health systems, and this is across the the whole value chain of health systems, starting from policy to operational efficiency to infrastructure to to digital health, to monitoring and evaluation. But I think in this whole situation, we have realized that the digital health can play a critical role to reach out to the last mile. While there have been a lot of efforts, but India is quite a fragmented, market from that perspective, and it has its own challenges. Government has been trying multiple, through multiple initiatives. They rolled out their own products like eSanjeevani and HMIS and others. But then finally, I think we saw their consolidated effort coming in the form of National Digital Health Mission, which was launched by the Honorable Prime Minister on 15th of August. While they conceptualize and gather all the resources to make it a reality on the ground, very soon. But then the challenge remains in front of us, ensuring that how the end beneficiary, which is a patient and probably a provider, are able to link, and a better healthcare service is being provided. Digital health enable all of it, but then challenges, looking at the resourcing aspects, looking at the technology aspects. I think some of these things are quite critical, and I'm glad that our panelists today have chosen quite a bit of topics from covering all of that full circle or environment, so to say, digital environment in the country. So I would keep my introductory note short and let our eminent speakers to talk more and understand their perspective. Our topic focus on the digital health, the opportunities and the road ahead. The sequence I have is Dr. Rajiv Sharma talking around identifying the real problems, which is very critical. And I think learnings from some of these real life challenges, evidence will help us to smoothen the rollout of such initiatives. Mr. Cody Hill will talk about experience in digital health, practice-based implementation, again, learning from the ground. Dr. Seema Singh will talk about at the point of inflection, a fresh perspective to look at what all would it take to make it happen. We've got Anurag Saxena, who's closely working with National Health Authority on the National Digital Health Mission, so he has chosen that topic. Dr. Sagar Aloni will give overall perspective on digital health. We've got Dr. Rajiv Singh, who will focus on the advantages and the opportunities. Then I would request Dr. Sandeep Nerula to come for a vote of thanks. So we've got about 10 minutes for each one of us. I would request, keep that in mind as all of us are online, talking today. I would request everyone to be on mute and let the speakers talk, uninterrupted. So let me request Dr. Rajiv Sharma to share his view on identifying the real problems with digitization of health and the opportunities to lay the foundation right.
Hi, thanks, Lokesh, and good evening, good day, everyone. I would particularly thank IIHMR and Professor Dean Shiv Tripathi for the invitation extended to me. Without wasting any time, I would say, I think Lokesh, you touched on very right points, how we need to really go deep dive and pick out from the field examples, especially people who've already been in the IT sector, who've seen in the West what has happened before, not to replicate the mistakes and learn from them. So to begin with, I would say we are actually sitting at a very interesting point, almost like a turn of century event, where in terms of digitization of healthcare, we have been preponed, or the digitization of healthcare has actually been preponed by at least 4 or 5 years, if not more, because of the pandemic. And that has also led to some hasteful decisions where we are pushing the realms of the boundaries, which is probably not the pace of the evolution as it's supposed to be. So which opens a lot of opportunities for all the people to collaborate and work together towards making this digital ecosystem as conducive as possible. So for next couple of minutes, what I'm going to do is I'm going to touch on identifying the problems, deep diving into the real issues, and also maybe a little bit of light onto the opportunities there. Now, what do we mean by digitization in healthcare? And why do we need it? We need it basically for reducing the cost of care. We need it to enhance the quality of care for the patient. It all has to be ultimately going down to the patient, which eventually will lead to the entire ecosystem enhancement and also the cost of reduction of cost when it comes to the entire healthcare ecosystem. Now, it's not as simple as it looks, because digitization means efficiency, standardization, and also scalability. Now, when we look at that from a healthcare and patient prospect, what really happens is we're talking of 3 points. We're talking of data entry, we're talking of data assimilation in digitization, and we're talking of making meaningful information out of data. Now, data entry is relatively easy. We've seen that in the West with electronic medical records. We've seen that with laboratory systems throwing a lot of data around the patient and overall inside the system, and a lot of non-clinical software systems. Making data meaningful or deriving some insight out of it also is not so new, because a lot of industries have a lot of analytical engines and AI and ML-driven engines. The important point here is the data assimilation, because we're talking from healthcare, especially from India or other Southeast Asian country point of view. We're talking of a patient going to hospital 1, 2, down the road, his family physician, his laboratory, then another laboratory, then variables, and even patient apps. So there is a lot of data on the timeline in the moment for the patient, but everything is siloed and fragmented and stored in different servers if we talk of it digitally. Now, when that happens, we are actually losing out on all the value that could have otherwise been generated that we anticipate when we are investing for digitization of healthcare. So what really happens here is, which is the key, that the cost of digitization offsets the economic benefit from the digitization of healthcare that's supposed to be derived. Now, when that happens, that leads to a whirlpool of events. For example, I'll just give you, to be objective, roughly $2,000 is the economic waste that happens when per electronic medical record in USA, because of duplication of data, because of redundancy of data and all of that. There is $400 worth of economic loss per medical record when there's a breach of patients' information or record. Now, if we go down the same route that all the rest of the geographies have gone through, we are looking at the multiplier effect in terms of Indian population that we can't even imagine right now when it comes to digitization. Forget the economic benefit that we'll get out of it. Now, what that leads to a very specific area of problem that we need to solve for, which is real-time interoperability. Because even when you take a small decision and there is a lot of data coming from different entities, be it a doctor deciding whether he needs to go for a surgery, and he looks at the patient and sees if he's got an insurance or not, and then he goes and sees what if his family is okay to undergo either stenting or bypass surgery. So when they're looking at decision making like that, everybody who's relevant, who's consented, needs to have that particular information around that patient, which has to be very continuous and complete and incorrigible. Now, that leads to a very pinpointed problem in healthcare, which is interoperability. When it comes to interoperability, again, interoperability has to be real time when we are taking decisions in real time, and also secure. When we are talking of systems of the nature of centralization or bringing together a lot of information as we need for decisions to be made for the patient, we are actually not there are two different problems, real time and security. So either we'll compromise on real time or we'll compromise on the security. So to enable both of them becomes, and to ensure that both of them are in tandem, that becomes the key issue here. Now, that's, if we further deep down into it, and let me give you one more example, that let's fast forward 5 years from now or 10 years from now. We're looking at patients with auto insulin pumps and sensors getting information around blood glucose levels, and also at the same time, pacemakers with imminent dignitaries and replacement of their batteries due. And this is all going to be digital. Now imagine if there is a 5-minute attack and there is disruption in this continuous flow of information across the ecosystem, the catastrophe of levels that we can't imagine. Direct millions of lives will be affected. Forget the economic loss that will come, because insurance companies will not be able to make a decision for the patient, or hospital will not know what to do with the patient in the immediate sense. So we are talking of a very interesting problem, or a foundation problem of nature. And not that other countries were not good who are digitally equipped already, but they were early adopters. And what really happened there was they kind of went ahead with how the IT was getting evolved, and they started taking 1, 2, or 3 or 4 modules from IT into healthcare IT. Now, that led to this fragmented and siloed nature of ecosystems that got developed there. So we have to be very careful in making sure that when we are going ahead contributing to the development of this digital healthcare ecosystem, be it for India, be it for other developing country which doesn't have digital ecosystem yet, we take note of all of these issues very, very carefully. Now, having said that, it's not that all is gray and black, but we have opportunities, and ecosystem overall is conducive right now, because we have, for connectivity, we have 5Gs coming in, for example. For technology, we have blockchain technology like technology, and we are actually working on it, and there are various protocols how to manage the data, not just for security, but also for consent, for incentivization, because why would everybody, be the hospitals or the doctors or the patients or others, contribute data if they're not incentivized inherently by the system? So we have those. Also, very particularly and interestingly, maybe 60, 70 countries out of, I think, 190, 192 odd WHO affiliated countries are actually, digitally enabled. So we actually have a lot of greenfield projects across the globe where we can start from zero, scratch, and leapfrog, like how maybe M-Pesa did in Kenya, or other projects where where they have not even had bank, but we can take inspiration from those different domains when it comes to healthcare. Now, what this leads to? This leads to a very collaborative effort between different parties in the ecosystem, so that there is a very forward-looking and forward-pushing kind of an approach to the ecosystem, where everybody has a lot of play to act, which will eventually lead to something we call internally in our company LOR, based on Lord of the Rings, which is nothing but longitudinal health record, which eventually will lead to all the problems and all the solutions that we talk when we talk of digitization and we talk of data usefulness, be it AI-driven analytics, be it even clinical research trial selections, drug discovery, and all kind of analytics that we talk on data can only happen when we have that continuous, incorrigible, and also complete data. And one more point here, that when it comes to security, like I mentioned before, security and in healthcare, according to me, it's more about continuity. If somebody peeps into the data, that's dangerous, but it's more dangerous if there is a discontinuous data flow once we are completely dependent on digital ecosystem, right? So that continuity has to be there and the security around it. Lastly, before I wrap up, I think in the name of digitization, we shouldn't forget something which is core to healthcare, be it even when we are talking of digital healthcare, when we are talking of digitization of healthcare in its entirety, we shouldn't forget something as simple as empathy, because it's all about empathy ultimately in the healthcare. And I, always call it digi-humanization of healthcare rather than just digitization. So if we can keep these tracks in mind, and then we can imagine with this ecosystem, all kind of applications, all kind of, there are a lot of applications like menstrual flow application, CureFits, and Healthify Me, and equivalent applications that can actually benefit the users eventually, with everybody benefiting collaboratively in the ecosystem. So with that, I'll just let Lokesh, you take the baton again to pass it to the next speaker. Thanks.
Perfectly on time, Dr. Rajiv. Thank you for your perspective. And I think valid considerations from a data integration standardization perspective. And I think as the country would have this evolved ecosystem, some of these things would act as critical pillars. I think Mr. Cody Hill would help us understand how it is being done in some of the projects where he's working on. So let us hear from him. Thank you.
Thank you for welcoming me to the conference, and I really appreciate IIHMR and all the support that has gone into making this conference a success. As mentioned, my work has been primarily the last 5 years out of the Dubai office for Houston Methodist Global, and we're an arm of Houston Methodist Health System, an acute care hospital system in Texas in the United States. So what types of work we do out here is mainly consulting, management consulting, and our clients range from governments to private sector entities. But in getting introduced to Pradanya, I had a unique opportunity to look at UN Sustainable Goal number 3, and I think that kind of guided me in trying to understand how I could present digitalization and the opportunities in the road ahead. Looking at those goals on health and well-being for the almost 80 countries that are being targeted, with the 3 major inventories of pediatric health, maternal health, and epidemiology. And then within those groups, the 13 goals, the targets that are set, those are all areas where digital health can help to achieve those outcomes for many of those countries. But in doing lots of market assessments all around the world for our company, I realized that each market is different. In fact, there are smaller submarkets within each country that might adopt technology at different paces or have the infrastructure available to them or the workforce available in a way that helps them to implement the technologies faster. So when I work in Dubai and try to set up a telemedicine system or telehealth system with our entity back in the United States, there's a lot of challenges, regulatory challenges that are here that prevent us from maybe hosting patient data anywhere else other than the United Arab Emirates. When I'm working in Saudi Arabia, that's less clear, and certainly in places like China, markets that we're in, it's more of a free-range system right now where patient records can easily be transferred abroad. So, when we're looking at intercompany or even intercountry relationships, we look at governance, we look at the regulatory environment. And going back to sustainable goal number 3, for sure, if there's already existing infrastructure, and by that I mean if there's telecommunications networks set up in different areas of different countries, those can be leveraged to implement the types of technology that can benefit patient care. And a simple example of that would be during COVID-19 pandemic, many people in Texas, for instance, where I'm from, were still going to their primary health physician up until March. And then all of a sudden, those visits leading up to potentially a surgery or procedure were eliminated by government mandate if they were elective or deemed non-urgent. So many providers, many physicians had to adopt the new technologies to interact with their patients. Many patients had to adopt the technologies to interact with their providers. So looking at what we could do in countries that are in the phases of development where digital health could impact them, are those infrastructures already available? And so, we would look at those with a particular client. Lately, we've been working with the government of Saudi Arabia on private sector participation, or as better known, private-public partnerships. So many of those have been offered in India that we look at when we're developing a plan, a proposal for, say, a country like Saudi Arabia. We tried to leverage the successes of previous programs that have been successful. So even in Rajasthan, there have been some successful PPP projects. So I think the financing angle of digitalization can't be discounted at all. And I think that maybe the private sector has the ability to execute in partnership with the governments themselves to offer these kinds of services. So those are the areas that we try to incorporate some level of digital health and outreach whenever we're proposing solutions to clients, whether they're small clinics or hospitals, hub and spoke models anywhere in the Middle East, or even governments that are trying to reach all their covered lives. So when we're talking about Saudi Arabia, we're talking about 20 million nationals, and we're talking about 290 different government hospitals that have relationships with lots of primary health entities. So, where do we see this going? I'd echo Dr. Rajiv and say that standardization is critical, and we face that challenge in so many ways. So if there's a thought process behind designing these systems in a way that standardizes the data in the very beginning, then it'll ultimately be easier to achieve that continuity. It's when we jump from system to system, there may be legacy systems that capture data in a certain way, and then we ultimately roll out the next groups of systems, the next iterations, and we may lose some of the integrity. We may lose track of patients' access to care along the continuum. So when he talked about the blockchain-enabled services that may be offered, we're always excited in our office to talk about that subject, because we think that patient health records can actually go from cradle to the ends of our lives. It's just a matter of who's willing to take the risk to do that, to capture that information about our health status and even our family history and other elements that could impact our health status throughout the course of our lives. So we're always considering those concepts when we're proposing for brick and mortar solutions, whether someone wants to design a new hospital or if somebody just really wants to come up with a digital health solution like teleconsultation or second opinion, or something that's provider to provider interfacing that extends the outreach of care. The other thing is about education. We know that in many of the countries we're working in, the extension of providers into those communities is critical, and then the extension of the technology in the hands of those that have the skills is important. So, we're always looking at how well positioned are the educators and to bring up the next wave of healthcare providers, and can we get those healthcare providers the technology they need to educate the public to use them in their home environment or in rural areas. So these are also, I think, valuable considerations when looking at sustainable goal number 3, and how can we ideate over what solutions will best elevate the health status for those particular areas. How are we reaching women who are in the early phases of pregnancy to encourage them to adopt better nutrition? How can we encourage them to seek out care from providers when there may be complications? And how can we best interact with our young people, our children, and those that are unable to really communicate what's going wrong with them? Those are areas where digital health, I think, will eventually capture things like facial recognition, understanding pain. At Houston Methodist, we have digital health solutions that we're piloting that are cameras that try to seek out what level of pain a patient is experiencing over the course of their inpatient stay. So, we believe that those types of technologies will leave the brick and mortar hospitals, be out in the outpatient centers, and maybe ultimately out into the community, so that there's a better understanding of the physiology that a patient has at the time that they're trying to engage with our health systems. So I think with that said, I'm excited about the future of healthcare, especially digital health, and certainly what can that do to offer better health status to those that need it the most.
Thank you, Cody, for wrapping up your session in time as well. The views you have shared around the private sector engagement and how do you link it with the SDGs. And I think at large, somewhere we should also look at, how this becomes an enabler towards the universal health coverage. But I think the views shared by Dr. Rajiv and you, Cody, gives us a perfect context for Dr. Seema Singh, where, she would share it at the point of inflection. And I think we've got enough context setting for that session. So Dr. Seema Singh, please share your views from here on.
Thanks, Lokesh. At the outset, big thank you to IHMR for giving me this opportunity. So whatever I'll be talking about why digital health, especially in the Indian context, is at the point of inflection, mostly comes from what I have experienced being working closely with digital health products for the past 5 years. So when I started working on digital health, I was like a fresh MBA graduate, a clinician coming to this side of the table. Accidentally, I landed with a digital health startup, and we started working on a chronic disease management software. And we started going to the market, reaching out to the doctors. And the first question that came back to us was, what's in it for me? So most of the clinicians, they were not able to see the value in any of the digital health products. And that was the question that was present across the ecosystem. Starting from that day 5 years ago to a day today, where we are talking about a national digital health mission, we are talking about how digital health is going to revolutionize the healthcare. It's been a long journey, and that's something that I'll be talking about as to how digital health has reached from that point to this point, where it is now ready to be adopted by the masses. And I would like to take a more of a ecosystem level view of this thing. If somebody could, the host could enable sharing screen, then I can share a few pictures and I can talk through pictures. Otherwise, I can talk just like that. So when we go back to talking about the SDGs, and as Cody also mentioned, the healthcare related SDG says only one thing. It aims to something called as a universal health coverage. And when we talk about universal health coverage, we mainly talk about the affordability, accessibility of healthcare. And after giving these SDGs, WHO in the year 2019 went ahead and did an analysis based on a very old framework, what they called as the Tanahashi framework, which is something which was designed way back in 1978. And what it does is it assesses the gaps in the healthcare systems and sees that progressively as you move up in a healthcare system, there is a gap in the baseline, which leads to the gap in the next level to be even larger. And progressively, the gap increases and our ability to reach what we call as UHC goes down. And that's where the concept of bringing in digital health to bridge those gaps came up. And that's where WHO came up with what we call as the digital health guidelines. So WHO in the year 2019 came up with guidelines, which are essentially recommendations as to how digital health interventions they can help in health system strengthening. And some of these interventions we already spoke about, Dr. Rajiv spoke about, Cody spoke about, essentially from things as simple as birth and death notifications to maternal and child health care to the entire spectrum of ecosystem. So WHO thinks that every step of achieving the UHC, digital health, will play its role. But what is it that will enable the digital health is something with which we will be talking about today. So what enables the digital health? And this is something also which comes from the same guideline. These are the 7 basic enablers that we think that will enable digital health ecosystem in any country. Especially if we could talk about a country like India, where in terms of digital health, we are essentially slow starters. So what we essentially need is a foundation layer. And this foundation layer is something which is like essentially about we should have an infrastructure, you should have a good legislation, policy, compliance in place. And only on top of this foundation layer will you ever be able to build interventions and specific applications, which can then go on to the delivery part of the things, which can actually help you bridge the gap going forward. So unless and until you have this foundational layer in place, the building up only applications is not going to help. And that is essentially somewhere the kind of difference that we noticed today. When we were working on digital health 5 years back, we were working with a very short-sighted vision of building applications. Maybe our focus was not even the Indian market. A lot of digital health applications in India have always been US focused. So we had been focusing more and more on how to build applications, how to come up with solutions, how to come up with AI applications and all that. While the foundation layer, where is the basic acceptance in the market, the basic leadership, governance, basic interest in the digital health in the market was missing. And that's the reason we were not able to crack this market. We were struggling with our clients where they were asking what's in it for me. Even if I do it, the ecosystem is not enabled. How is it going to tie up with a bigger picture? How am I going to derive benefit out of it? And that is something which has now changed. And how it has changed, let's see. That is why I now feel that this is the point where digital health in India is at the point of its inflection. That's because we have somewhere started looking at taking care of this foundational layer before we go on to really building applications on top of it. And what is this foundational layer that we are talking about here? First is the leadership and governance. And we all know what National Digital Health Mission is trying to do. It is trying to create a uniform structure, uniform guidelines across the country, on the top of which various applications can be built, where everybody can be, all the healthcare providers, all the healthcare systems, all the healthcare facilities can be brought under one umbrella, and they can look at exchanging information and creating the larger ecosystem. So when you talk about providing the leadership and governance, NDHM is one of the biggest steps that we have seen over the last few years in this direction. And I think Anurag in the next session will be talking in more detail as to what NDHM really entails for the changes in the digital health. So now the leadership and governance is in place. We're trying to roll out NDHM, and that's one big step towards enabling the ecosystem for digital health in India. Strategy and investment. So this graph is more about the across the world funding, VC funding for digital health, but we all know that it's kind of a reflection on how the interest is there. And any business can survive only if there is enough money, there is enough funding for, and especially about healthcare businesses, what we say is, if you have to build a successful business in healthcare, you need to have deep pockets, and deep pockets mean a significant amount of funding, a significant amount of interest from the VCs and the PEs of the world. Only now when the VCs have started openly seeing opportunity in digital health, that the digital health as a ecosystem is now getting strengthened, and we say that it has reached a point of inflection. Then a part of the National Digital Health Mission is also to look at the policies and compliance. Till now, whenever we spoke about digital health, a lot of questions about data handling, about the security of data, privacy of data would come in. And everybody would say, see, in US, if you build a solution, there are very clear-cut data policies and guidelines. In India, do you really have anything? So DISHA, that is the Digital Information Security in Healthcare Act, which is still under consideration, is a large step in that direction, wherein we now have our own health data policy and guidelines. Services and applications is something which we were never in dearth of. We had started from this layer without even having the base layer in place. And according to a blog, there are 150 plus digital health startups in India. And all these are working on building the various services and applications. Only that has changed now is now with a strong foundation layer, with a strong governance and the compliance layer built at the bottom. All these startups, they are more likely to see success than what somebody would have seen a few years back in the digital health ecosystem of the country. Infrastructure, we all know there is a good cloud layer. We have enough computing space. That's where now the second generation of applications are coming up. Earlier, we were only talking about EMRs, EHRs as the digital health applications. Now, because we have enough data, we have enough cloud computing power available, we have enough infrastructure. We are now talking about things like AIs. And so in my journey, the first company that I worked with was essentially collecting data from the patient and showing it to the doctor, a very basic information communication. And the And going forward, when we started working, we were working on using AI for infection management, AI for predicting things like antimicrobial resistance, for picking up which antibiotic should be given to the patient, which patient is more likely to develop a resistant infection. So with the development of this infrastructure, the level of applications that we see in digital health has gone from a basic data collection tools to more higher AI and ML enabled applications. Standards and interoperability, Dr. Rajiv also mentioned, has always been a big challenge. And this is something which even the developed countries, the developed ecosystems still face. And in India, we all know how much we struggle with this interoperability. Standards have existed, and with NDHM coming in, we hope that more and more of these standards will now be adopted, adhered to, and interoperability will progressively become faster. Uh, to give you an example on challenges with interoperability, even when we were building on AI solutions, which essentially uses data from lab information management system, the biggest reason why the solution was failing in the market was we were not able to integrate with the lab information systems, and we were not even able to pull data, and not to talk of using AI on top of that data. So interoperability is something which can make even the best of the applications, best of the AI algorithms fail, for the simple reason that you can't even pull information. It is residing in so many silos that there is no use of that data or information. Workforce, we can see there is so many of us who are now working in digital health, proudly calling ourselves digital health evangelists. Earlier, digital health was one corner of the healthcare. Now it has obviously become mainstream, and there is enough and more trained workforce available. Especially in India, the technologically enabled workforce has never been a challenge. We have been the technology center of the world for a long time. So workforce has always been there. So these are the few factors which I feel are what is enabling the digital health ecosystem in the country now, and that is the reason why digital health in India is currently at the point of inflection. And if you ask me what is the game changer, then obviously it is the National Digital Health Mission, which is trying to build that much required base layer, the foundation for the AI applications and digital health applications to grow and make a difference to the goals of universal health coverage and the SDGs in the country. And essentially, no discussion about digital health can be complete without talking about what the current pandemic has done to this space. Essentially, the space which was being enabled by the likes of Digital Health Mission there has been a catalytic effect of the pandemic. Digital health, which was earlier seen only as a kind of one option, has suddenly become a very, very mainstream focus of the country. Now, acceptance of digital health at all levels, including from the doctors, from the patients, from the other players in the system, has suddenly increased, because in the pandemic, people have realized that if you have to increase your reach, if you have to reach the patient in the farthest corner of the world, then digital health is the solution that you have to go to. So is all is well here? Well, as any other solution, the way ahead does have challenges. And I'll just quickly talk about one challenge which I always feel that any digital health solution needs to solve for. Although other things like problems, innovations, market acceptance, everything seems to be gradually falling into place like the cogs of a wheel. But one big challenge that still needs to be that everyone needs to face and everyone needs to solve for if they want to create a meaningful digital health solution is the product market fit. And when we talk about product market fit, it's just 3 words, but what it actually encompasses is an end-to-end viability of your solution. It includes whether you have chosen the right problem to solve. And when I say the right problem, it's not just something that you feel is right. It's something that your end user also feels is the problem for them to solve, and it is significant enough for them to put their effort and energy into learning something new, maybe some financial cost also. So defining the problem and defining the right solution for that problem, and when I say right solution, it is a scalable solution which is commercially viable. So answering the question of product market fit still remains for most of the digital health applications. Only when you answer this question, in spite of all the ecosystem enablers, in spite of all the the policies like digital health mission and everything in place, if your solution is not able to answer the digital market, the product market fit question, it will never be able to make any difference to the lives of anybody. There will be no users, so obviously you will be not be able to make any difference to the world. So that is the biggest challenge that remains to be answered. So just to summarize, when we are looking at solving the product market fit challenge, a few things that the designers of the solution need to look at is design for the user, design for scale, and build for sustainability. Only when you have a larger picture, the long-term vision in your mind, you build for scale, and you know that how your end user feels, how important the problem is for them, can you develop a sustainable and viable digital health solution, which can go a long way in solving the health problems. That was all. Thank you.
Thank you, Dr. Seema, for interesting views and the slide deck you shared. I think also you've been highlighting, the user perspective, what's in it for me, the foundation layer. I think these are some critical factors from an adoption perspective, and we've realized in India, some countries who are advanced in digital, health rollout, they also face similar issues. So I think, thankfully, we've got Anurag with us to talk about National Digital Health Mission, and I hope he can throw some lights on some of these factors, starting from what Dr. Rajiv said initially, the integrated data mechanisms. What Cody said, private sector, because in market like India, where a large share of or the large service provider segment is the private sector, and third, what you said, Dr. Seema, which is around the adoption component, how NDHM is going to address some of these aspects.
Thank you. I'll just try to share my screen. I have some slides. Let's see if we can quickly run through. So first of all, it's an honor and a privilege to address this gathering here. My name is Anurag. I'm a principal with IQVIA. Right. So as Lokesh mentioned, we have been working with the National Health Authority as the consultants for National Digital Health Mission since June last year. And we had a simple problem, right? Idea was that India had a blueprint ready. The National Digital Health Blueprint was prepared some time back, and the government wanted to quickly roll out the mission and see how the building blocks can work in action, right? So maybe I'll quickly start with an introduction to what is NDHM for those of you who are not aware. I think Dr. Seema has briefly spoke about NDHM, but just to share some thoughts around NDHM, what is the vision? So idea is that, if you look at what India has done in the last decade or so, India has created a lot of digital public goods. For example, Aadhaar provides digital identity to every citizen or every resident of the country. Similarly, India has also implemented very good platforms when it comes to digital payments. So UPI is one success story that we have. So idea is, how do we replicate that story and implement digital health in India so that we can leapfrog other countries in showing the world what can be done with digital health and at scale, right? So if you see the slide, the vision is obviously to provide universal health coverage and a platform that enables the industry overall to participate. This is not just government trying to insist on some mandates. This is about creating an ecosystem that enables digitization of the overall ecosystem, right? So the simple problem that we have was that citizens don't have access to medical records. Very simple problem. We are looking at citizens who have to carry physical files when they move from one hospital to another. They don't have access to information about doctors and hospitals. So if I want to look at nearby hospitals that can provide treatment on cancer, there is no authentic source right now, right? So this is a simple problem that we're trying to solve. Then, when we talk about doctors, we don't have any authentic source of information about the knowledge or qualification of the doctors. So how do we solve that problem? And also to look at providing choice to the citizens when it comes to platforms like teleconsultation, and also look at emerging models around e-pharmacy, right? So for citizens, this is the problem that we have, that we are trying to solve with NDHM. For hospitals and doctors, the simple problem was that doctors don't have access to patients' medical history. They have to rely on physical files that patient have saved in the past, right? that helps to provide the history of medical records. Then we don't have the ability to follow up after treatment, because there is no digital sharing of information right now, right? So in bits and pieces, there are some hospitals that have adopted some bit of technology, but at a national scale, if you talk about one patient moving from, let's say, Apollo Hospital to Medanta, there is no sharing of information right now, right? Then the facility to remotely consult patients was not available, especially in COVID times. We realized that this is something that is required at a national scale. So NDHM tries to provide a platform that will ultimately enable all these things, and also looking at ease of doing business, right? So hospitals have a lot of clearances, a lot of procedures to be followed. Let's say, if you have to enroll the hospital with a scheme, for example, if they want to onboard with an insurance provider, there is a lot of paperwork required. So once we have digitized data available, we can quickly enable all these things electronically. You don't have to feed information, fill up manual forms, and quickly share information in a digitized way. Looking at policymakers also, and the problem was that policymakers don't have access to information that can be used for decision making, and they don't have control over what is shared with whom, right? So NDHM is trying to solve these problems for these simple groups that we have on the slide, right? So the objectives are that we have to establish a state-of-the-art digital health system that's a platform, right? We are not looking at standalone applications. We are looking at overall ecosystem getting digitized. The quality of health data has to improve, right? So on the previous slide, we saw that we don't have source of information about hospitals or doctors. So how do we improve the quality of health data? How do we create a platform for interoperability, right? So in layman term, right now, if hospital A wants to talk to hospital B, they don't talk in the same language, right? Somebody's talking in French, the other person is talking in Latin. So how do we standardize and create interoperability of data through healthcare standards? And how do we fast track creation of registries? The answer to problem on the previous slide is to create a registry at a national level. Whether you talk about a doctor or you talk about a hospital or labs, if there is a national registry created for these areas, I think the information can be standardized in a fairly quick manner, and also to provision quality of care, right? So ultimately, all that will lead to improvement in quality of care. So the guiding principles for NDHM are very simple, right? One is going by privacy concerns, specifically looking at Aadhaar as an example in the past, right? We are looking at voluntary participation. Government doesn't want to force anyone to create a health ID or opt for any digitization of their medical records. The participation is kept completely voluntary in nature. Privacy and security is ensured by design, right? So Dr. Seema spoke about the policies that have been enacted. For example, the health data management policy that was put up for public consultation. There were a lot of comments and suggestions received from public in general. And the design of NDHM has been kept in a way so that the voluntary participation of citizens is ensured, and also any sharing of data. Ultimately, we treat patient as the owner of health data, right? So no data will be shared without citizens' explicit consent, right? So that ensures privacy and security by design, so that there is no misuse of data. Especially when we talk about health data, there are a lot of concerns specifically around misuse of health data, right? So by using these enabling policy frameworks like health data management policy, this part has been ensured. Also, we are looking at inclusivity. While we are creating smartphone based applications, we are creating web based applications, we also realize that the villager, without having any devices, he should not be left out, right? So idea is to create ecosystem that is inclusive, right? So if I want to create an electronic health record sitting in a village, even if I don't have a smartphone or I don't have a laptop, I should be able to go to a nearby CSC or maybe a post office or any other digital point in the village, where somebody through an assisted model can help me in creating a health ID, right? So that is the fundamental approach. Also, we are looking at seamless portability, right? So given that we are looking at a national platform being created, we are looking at providing option to a citizen when he moves from one city to another or one hospital to another. The data should be seamlessly available, because we are looking at data portability and also standardization of data standards. We are also looking at a lot of initiatives to make sure that citizens are aware of what is happening, right? So currently, NHA is doing a pilot in 6 union territories with NDHM. It's limited number of modules, but the idea is that once it goes live at a national level, there will be significant focus on educating the customers or the beneficiaries on the benefits of going for digitization of healthcare records and adopting NDHM platforms. So if you look at the building blocks that are currently live in the pilot phase of NDHM, Health ID is one of the critical component that provides an identifier to each citizen, right? So you can link your health record to your Health ID. The idea is that, by design, we have kept Health ID as non-unique because, there are some people who may not want to share a specific health ID. For example, if you are looking at a psychiatric problem for a particular individual, and he goes to a hospital for a one-time treatment, he may not want to link that particular health record with his normal health ID, right? So we want to provide that choice that it is going to be not unique by design, but if you link it to any scheme that is linked to a government subsidy scheme, then you have the choice of linking it to Aadhaar, but we are still keeping that option open. The second module that is currently live is called DigiDoctor currently. It is the registry of doctors in the country. It is not only talking about allopathic doctors, but we also have a provision to onboard Ayush doctors, right? Then the third key building block that we have is the health facility registry. That's a database or registry of all the hospitals and labs in the country. So currently it is only looking at the 6 UTs that we have, but going forward, this is going to go live across the country. And the good part is that NHA will not be the business owner of these registries, right? So ultimately, the business owners, for example, the medical councils or the regulatory bodies, they will remain the business owners of all these registries. NHA is just creating the technology platform, right? So we have clearly differentiated between the business owner of a platform and the technical owner, so that the data is controlled by the relevant regulatory body or the agency that is supposed to control, so that there is no confusion of ownership. Another interesting module that has recently gone live is the personal health record. So there is a mobile app on Android, Google Play Store, that has been launched in a limited way. So you can link your health ID to your personal health record and make sure that, if you want to share your personal health record with a particular hospital that is onboarded on the ecosystem, you can do it through consent, right? So it is very similar to UPI construct where you enter your PIN and provide your consent when you want to authorize a payment. In a similar way, when you want to share your health records, you can do that with your PIN or consent. Telemedicine and e-pharmacy are currently under consideration because of regulatory things, but I think we will very soon go live with these modules as well. Ultimately, the core building blocks, which are the registries, they will be controlled by the government. But the idea is that government wants to keep it open for private sector participation also, right? So very quickly, if you see this slide, on the left-hand side, you have hospitals, diagnostic centers, and clinics. And there is a reference app called EMR web app, which is actually meant to digitize hospitals functioning, right? So how do you create data in a compatible format, right? So we were discussing the problem of hospital A talking in a different language, hospital B talking in a different language. So through FHIR standards, we are trying to standardize this problem of language. So we have a simple healthcare data exchange format, which is enabled through this reference app, right? So if a hospital doesn't have any HIS or EMR software today, they can make use of this free application, which is a reference application similar to what Bheem is for payments, right? So if a hospital is not digitized and they want to participate in the ecosystem, they can download or make use of this free application, start generating data in a compatible format, which can be understood by other participants in this ecosystem. Now this data goes to the consent manager and gateway, right? So I want to fetch my records from hospital, which is connected onto NDHM ecosystem, and share it with another doctor or another hospital. That goes through this gateway or consent manager. And we make sure that, data is shared in a controlled way. You can also control the duration of data being shared, right? So if I want to say that Apollo can access my medical records for the last 7 days for next 1 week, I can control that. right? So that's a level of control that we are going to provide to the citizens and ensure that data is not compromised, specifically talking about electronic medical records. And you can also have private sector providing compatible application, right? So if you see the slide now, so while government is providing a free reference application, you are free to use any compatible software as long as it complies with the basic principles of NDHM, right? So there is a sandbox environment that NHA has created where private sector HIS and EMR vendors, they can quickly onboard themselves, they can test out their integration and start generating data in a compatible format. Similarly, for PHR, the personal health record app, there is a choice to the citizens that they can make use of commercially available PHR apps going forward. So in the same way, right? So you had BHIM application for digital payments earlier, but you also had the choice of downloading a Paytm or a phone pay later on from private sector. So that's a similar philosophy that is being adopted here. And I think that will really help in accelerating the digitization of healthcare in India going forward. So just wanted to keep it brief today. This is a topic that can go on, and we can talk about it for hours. But just wanted to give you a quick overview. What is NDHM and what is the basic philosophy? Back to you, Lokesh.
Thank you, Anurag. Very comprehensive information. And I think a lot of clarity around, some of the views which we have, heard before your session, that how some of those considerations, are being kept on radar. And it seems that there is a thoughtful, structured approach which has been considering. And I'm sure this will evolve as well. And I think the objective is to create a platform, an environment, rather than just a product-specific approach. So thank you, Anurag, for that. We've got Dr. Sagar Aloni. Would request him to share his views on digital health, please.
Hello, everyone. Thank you, IHMR, for inviting me. Thank you, everyone. I heard about Dr. Anurag, Dr. Rajiv, Dr. Seema Kodi talking about data integration and national digital health record system. And although it sounds very exciting and it's very promising, I would like to take a step further. There's one thing of integrating the data, and how the other thing is how we can make it more meaningful for the users also, not just for the doctors or providers, just for the patients also. I also look at it as a tool that will save lives in future. There is so much of data lying around. How we can intelligently work with the data and how we can make it more meaningful for the patient and for the doctors to identify early symptoms or early problems, diagnose a condition much faster than that you would usually do by making a sense of all this data. It's a huge job, and I understand because we at QI Spine Clinic and First Doctor are working on similar project. We have a fraction of data that the national digital data would have, and we still struggle with our data. We have so much to learn, we know so much about our patients that maybe we can treat them very fast and very more accurately. But currently, the project that we are working on is focused on exactly that, and we are working on AI-enabled system, which will crunch the data of our patients, and it will show to the doctor as to what next steps they can do for the patient. So basically, it will gather data like medical analysis, history, comorbidities, and any other personal factors like the sedentary lifestyle, or there's so many indicators that we capture, and we are going to churn that data and smartly tell the doctors as to how they should start the treatment. Okay. Once they start the treatment, they'll also guide what are the next step in the treatment. We are into the physiotherapy practice, for example, and every visit is equally important. Every visit is critical for the patient. So the whole app is designed in a way that once the patient starts his journey, the doctor gets a recommendation as to what treatment he should start with. Once he progresses towards the treatment, the app also tells about how the treatment is progressing. Is it slow? If it's slow, why is it slow? Or it's not progressing, why is it not progressing? Is there any mistake that's happening from the doctor's point of view? We go back. The system directs the doctor back and asks them to reclassify the case. Maybe the diagnosis is incorrect. So we are trying to develop a technology surrounding the data that we have with us, and create a smart solution that will not just help the doctors, but more importantly, will help patients to get recover faster. And with this this project, that the National Data Integration Project, I feel the next step, other than gathering the data, gathering the documents, would be to really smartly present the data so that it saves lives in the future, and maybe help somebody, and maybe encourage our citizens to join the portal. I mean, it's a big first step, I understand, and it's a commendable effort by the government and teams that are working on it. But I think we should also aim at the future, and how I mean, right today we should, and they could be already thinking about it. That's one point. Second is about artificial intelligence. How can we what other companies are doing? How can we as a unit use artificial intelligence to help the general population? We should also read about Dr. Watson. I mean, it's a big effort by IBM. I mean, I don't know if you all have read about it. Dr. Watson is a project that started in 2012 earlier, and now, since 2015 they are trying to enter into healthcare. They're trying to do similar thing. They're trying to tell physicians what they should do. Basically, it's not picking up the way it should. But I feel with all these efforts, it will really encourage small companies as well as the bigger companies to put in more efforts, put in their intelligence, and put in their money behind developing some smart tools that will help save lives. I think the future is AI, and future is AI to help the patients save lives and get faster and better treatment for our citizens. That's the future of the digital healthcare, I feel. With that, I think it's a very should.
Thank you, Sagar. And I think what you highlighted, structured data and use of predictive analysis and AI, can actually be life-saving and enable well-being of a lot of patients. So thank you for those thoughts. I would request Dr. Rajiv Singh to share his thoughts around advantages and opportunities of digital health.
Good evening. First of all, let me thank Dr. Tripathi for inviting me. And I was just looking at the screen, and I'm happy to be among all the doctors. And I think there are very interesting insights. And although I joined a little late, sorry for that, but I was listening to some of the insights. And I was thinking, if one looks at the future of healthcare, so how is India doing? And I've been tracking this space for last few months. Thanks to COVID, I think the technology adoption has gone up. And in all the spheres, people who never had any interface with the technology, today they are using it very well. And that gives a huge hope. Government has been talking about adoption of digital tech in various spheres, including health. And I think 2019 has really supported that effort and given it a big push. Now, if you look at the whole digital healthcare matrix, and it's a multi-dimensional matrix. On one side, you have the providers. On the other side, you have the seekers. Among the providers, you have the government and you have the private players. And among the private players, you have startups which are going to play very important and deciding and definite role going ahead. So how this whole ecosystem, because from the third side, you see the need for the financing, because this whole effort will need huge funding. Now, who is going to fund that? And another dimension is the technology and the human resource. Now you see all these dimensions having intersection at various points. And if this whole thing really has to take a big leap, I think we'll have to ensure partnership among various players. Let it be government, let it be private sector, let it be society. And at every intersection node, we will have to ensure efficiency. And we will have to ensure that there is a seamless linkage throughout. Otherwise, this whole thing will not work. And the objective of taking healthcare to masses, because even now affordability is a big issue. And if the fruits of this entire digital revolution has to reach people, I think it's important that there is ecosystem for which I would say government has a big role to play. Especially in the recent budget, one has seen more allocation for the healthcare, more focus on infrastructure. The schemes like Ayushman Bharat, Modi Care, that's another effort. And for this entire digital healthcare, what we really need is the digital infrastructure to be in place. There again, government has a big role to play. But what I'm seeing and what is happening, I think the professionals, startups, doctors, and all the technology providers, policymakers, I see a synergy. And these may appear very diverse groups, but if you have an aerial view of the whole thing, you find these diverse group more or less moving in the same direction. And that gives a huge hope. And going ahead, India will see investments in equipment manufacturing, digital healthcare. Government is opening up the FDI space. The recent reform in terms of insurance sector FDI opening up from 49% to 74%. And similarly, many other reforms, whether those are in terms of labor, those are in terms of taxation, transparency, predictability of policy. So I think we are all in for very exciting times, and the technology adoption, thanks to the revolution in terms of access to the mobile, I think mobile will become one of the important tools for the delivery of the digital healthcare. Obviously, like data analytics will play important role, AI will play big role, and people will have access to the best of resources, the best of doctors, the best of technologies. And I'm personally very, very hopeful. And I would only say that all the stakeholders have to work hand in hand. And I'm personally very hopeful. And I think the people who are there on this platform today, the professionals, people who contribute to the healthcare in terms of the knowledge of healthcare, in terms of the technology, I think we, the people, are really going to drive this. Thank you.
Thank you, Dr. Rajiv. With this, I think we've had views from all our panelists. Amazing views, interesting thoughts. I hope we would have got some clarity around this subject, and somewhere people working on different initiatives would appreciate some of these guiding principles which have been shared by our eminent speakers, and will be able to utilize them somewhere. So before I pass on to Aishwarya, do we try to respond to some of the questions?
Yeah, Mr. Lokesh, I think we can take one or two quick questions, because it will be then injustice with the participants who are there. So please do take.
Yeah, I think let's pick up the first one from Dr. Apurva, which is about how useful is digitalization, for people living in rural areas and uneducated masses. So I would request, Anurag to take on that question. Reason being, he outlined the structure of NDHNM, and I'm sure government would have thought through that. So Anurag, if you can, share views on that.
Sure. So I think in my slide, there was one point on the guiding principles that inclusivity is one of the guiding principles for NDHM, right? So, what will happen is if a rural person goes to a hospital, at least he will have a mobile number, right? Or at least a government ID. Using that, his health ID can be created in a necessitated mode, and whatever health records are created with the hospital, citizen has no dependency on his own IT equipment, right? Hospital will provide that infrastructure and share it, keep it safe with other hospitals, right? So when I go from a village A to village B, I as a citizen just need to provide my health ID, right? So even if I don't have any laptop or I don't even have a smartphone, the enabling infrastructure that NDHM is creating, that will make sure that I am able to participate in the digital infrastructure that is being created. Does that answer the question?
Thanks, Anurag. And once again, thanks everyone for joining in. Thanks speakers for sharing your views. I would request Aishwarya to take it from here.
Thank you, Lokesh sir. Well, that was quite an insightful discussion on digital health, its opportunities and the road ahead. I'm sure all of our attendees would agree to that. I would now like to call upon Dr. Sandeep Narula, Associate Professor at IIHMR University, Jaipur, to extend a word of thanks for our eminent speakers. Over to you, Sandeep sir.
Thank you very much, Aishwarya. Really, it was a wonderful session because the way everybody has given their insights, keeping in view the challenges and the opportunities in terms of the digital health, it is phenomenal. And in case if Dr. Sheenu Jan is there, who is heading the Center of Innovation and Incubation for Entrepreneurship, I think she must be excited and thrilled also because the amount of opportunities which has been exposed by the esteemed panelists to our students, I think they are phenomenal. They are phenomenal. And from there, in case if they can take the lead and in case if they start working on, or if they start working on the incubations of these ideas, I think it is going to make a wonderful journey for each and every student. Now, making a comparison as compared to last year, 2020, early January, when we were brainstorming with a few industry professionals that how the digital transformation is important for the healthcare and the pharmaceutical industry. Trust me, it was a very difficult nut to crack, and it was very difficult to the business leaders to convince. And if you all remember, if you all are there on the social media, there were memes which were floating on the Twitter that who is responsible for digital transformation in pharmaceuticals and healthcare, whether it is CEO or it is CTO or it is COVID-19, and the answer we all know very well. So we have been attending the webinars continuously from March onwards, where we were forced to sit, and now the challenges and the opportunities which has come to us, it is absolutely a new dimension. Today, nobody is talking about that digital transformation is important. Everybody says that yes, digital has reached to all the business organizations, and virtually it has changed and ramped up the business models of each and every healthcare and pharmaceutical organization. This is the reason that we have taken up this particular conference. The theme of the conference is solely on the digital front. I'm extremely thankful to our esteemed panelists, starting from Dr. Rajiv Sharma ji, who has talked about that how the data entry, data assimilation, and data insights are important. And without data insights, because we know data is the new oil, without this, the digital transformation is next to impossible. Mr. Cody Hill, he talked about how the private sector can take a very, very important role and can take a leapfrog approach at the digital front. Dr. Seema Singh, he very clearly highlighted that how the universal health coverage gaps have been broadened and how these gaps, the government and the private sector together, along with the WHO guidelines, they have to be bridged up. And Mr. Anurag Saxena, what a beautiful presentation, sir, on the National Digital Health Mission. Even a class 4 student also would have clearly understood what actually this particular concept is and especially my IHMR student, they might be feeling very thankful to you that this particular presentation has helped and enriched them immensely. Thanks a lot, sir, from the bottom of our heart. Mr. Sagar Aloni, he focused on multi-channels and then and only channels also, that how actually the patient and the doctor's journey, it can be covered from multi-channel and can be summed up at the only channel. Dr. Rajiv Singh, sir, thank you very much, sir, for highlighting the importance of public-private partnership and reinforcing that government is going to support at any cost, come what may. And especially when it comes from an official like you, on behalf of the FICCI and the Indian Chamber of Commerce, I think the mood of the students will go upbeat, and definitely they are going to invest very heavily in terms of entrepreneurship. Thanks a lot, sir, for enhancing and enriching and motivating our students. And last but not the least, Mr. Lokesh Sharma, what a wonderful anchoring, sir, you have done, and how single-handedly you have maintained the flow of entire plenary session. Thanks a lot, sir, from entire IHMR University and from our students and faculty members. Thanks a lot to all of the esteemed panelists.
Thank you, and have a
Thank you. Thank you.
Thank you. Thank you. Thank you.
Thank you.
And thank you very much, Dr. Narula, and all the esteemed panelists for your time and wonderful discussion. Now we move to next panel.
A very warm welcome to one and all present here. I am Dr. Urvashi Kapoor, and I thank you all for joining today and for the second plenary session, Leading the Change for Technology Adaptation in Healthcare. The chair for the second session is Dr. Adnan Kisa of Health Sciences, Christiania University College, Norway. Dr. Kisa has an extensive global health and policy research experience focusing on health administration, health and economic development, health services utilization, comparative health systems, cost of illness, cost effectiveness interventions in healthcare, and health outcomes research. We welcome you, sir. Moving right along, it is my pleasure to introduce our guest speakers, Professor A. Venkatraman, Professor, Faculty of Management Studies, Delhi University, Delhi. Professor Venkatraman is working in the area of HRD and health policy. He received master's degree from Tata Institute of Social Sciences, Mumbai, PhD from Faculty of Management Studies, Delhi. He also received advanced professional training from Harvard Business School, Boston, and World Bank Institute, Washington, DC. His research interest is focused on exploring and leveraging public-private partnership options to improve equitable access to healthcare services for the poor. We welcome you, sir. Professor Venkatraman will be joining us in a while. Next, we have with us Dr. Sutapa Bandyopadhyay Niyogi, Director, IIHMR, New Delhi. Dr. Sutapa Bandyopadhyay Niyogi is the Dean and a public health specialist actively engaged in research and teaching at International Institute of Health Management Research, Delhi. She is an MBBS from Nil Ratan Sirkar Medical College, Kolkata, and MD in Community Medicine from Postgraduate Institute of Medical Education and Research, Chandigarh, and Diplomate of National Board in Maternal and Child Health. She has a rich experience in public health and is particularly interested in implementation of projects that is relevant to national policies and programs. We welcome you, ma'am. Our third speaker for this session is Ms. Aise Besak Sinner, Healthcare Leadership Coach, University of Dundee, UK. Dr. Sinner is a distinguished health coach and a senior research fellow at Dundee Dental Hospital and School, Dundee University, Scotland. She is currently working on a project, a health coaching training for prisoners in cooperation with NHS Scotland. She is also working on implementation of health coaching training for administrators and healthcare providers for prisons in cooperation with National Education Board, Scotland. Dr. Sinner holds a PhD and DSCI from the University of Helsinki, Finland, and an MBA degree from Istanbul Business Administration Faculty, Turkey. We welcome you, ma'am. Now, I would like to request Dr. Adnan Kisa to take the session forward.
Good afternoon, good morning, and good evening. So we are international. I am joining from Oslo. So in Oslo, it is around 3:15 p.m. right now. I know in India it is almost evening. UK, it is almost afternoon time. In US, it is very early morning time. Thank you very much. We have really wonderful speakers today. Before I start my session, I would like to thank the administration of the university to host such a wonderful conference right now. It is the 25th anniversary of this conference series, and especially in these Corona days, you are bringing many international scholars together. It's a kind of medicine for us now. It's a kind of motivating factor. Thank you very much for this. I would like to remind all my speakers in my session that if you use like 15 hours for your presentation and 5 minutes for your questions and answers in your speech or in your presentation, it will be a really good opportunity because we are starting a little bit late. But first, I would like to go with Dr. Ayşe Basak-Çınar. She's from also Turkey like me, and I would like to start with her. If you are ready, Dr. Ayşe, I would like to invite you to the floor to give your presentation. Thank you.
Okay, thank you, Dr. Adnan Kısa. Thank you also to the university because it's a privilege for me to be here today, and I'm really happy. And I would like to say good afternoon, good morning, and also good evening, afternoon to everyone. It's 2 p.m. in the UK, by the way. So I will see if I can share my screen because I have a presentation. Yes, I can. But before that, may I invite everyone to type in the chat box how they feel today. How do you feel today? Because this is how I always start my talks or presentations. So may I invite? Or if you want, sometimes I do something like this. I ask participants to draw how they feel to a paper and share with me. Okay, that's great. I'm seeing all positive energy on the air, and that's a great sign. Actually, this is one of the exercises I do, and it's part of building emotional intelligence. So that is also starts to with people on digital platforms. So this is just trying to create a more human interaction. So. And today I will talk about leadership for digital transformation in healthcare. And I would like to ask first of all, is digital transformation all about technology? Actually, it is not. Actually, at the very core, it is about a change in mindset, a change or shift in mindset for leaders, for organizations. And that brings us the concept of leader. A true leader is the one who knows the way, goes the way, and shows the way. So actually, let's start with first where we are at the moment. Actually, we are at Industry 4.0, which is characterized by globalization, artificial intelligence, automation, and also digital technology, but also new leadership styles emerging. In 2019, a report by Delegates has shown that there would be an exponential change in digital transformation in healthcare, and it wouldn't be a linear one, it would be exponential one. COVID-19 has largely sped up the digital transformation of healthcare and boosted innovation in how patients can receive and consume care. In the same report, in alignment with other reports and research, it has been shown that the future of health will focus on well-being and prevention rather than diseases or rather than treatment. And all will be driven by interoperable data and smart artificial intelligence to identify illness early, enable proactive intervention, and traditional jobs will either be lost or will change, and health will emerge. And we will get closer to the patients both physically and and digital. There will be a wider range of software applications, wellness products, even health-focused foods, and all these assumptions are global. While this is one side of the future health, the other side is being human and human values. And actually, that is humans' need, and humans want to know they matter and they are being cared for. And by the research after COVID-19, it has been shown that companies that are the most human-centric and have the deepest personalized engagement with both employees and their customers will emerge faster and stronger. So when we talk about digital transformation, we are also talking about the balance between digital transformation, technology, and the being human or working with human values. And of course, COVID-19 made future now, so we say future is now. When we talk about now, new environment, new future, and new reality, also we talk about a new leadership style. I call this all-in-one leadership because actually it is transformational, resilient, and coaching leadership style. And this leadership style enables the three pillars of digital leadership, which are intelligent, emotional, and digital. And how about this new leadership style, blended new leadership style? It is because of COVID-19, because COVID-19 crisis has led to think and also created a need to rethink about patient experiences, value propositions, services, and operations to maximize the performance, health outcomes, and satisfaction of patients and healthcare professionals, but also to improve the health and well-being of professionals and also patients. And regardless of the type of the sector or the organization, either service or product, all organizations are undergoing a change, and actually the organizations will have a new structure, and this will be the three reinforcing elements of every organization globally after COVID-19. And it is purpose-driven, culture and value, and all these needs to be revisited. And all around this, there will be decisions, learning, structure, platforms, talent, and ecosystems all restructured. And when we talk about platforms, we see digital transformation, artificial intelligence, but also social networking remotely or traditionally, but present and future focused. So it will all change. Again, it's human centered and technology centered, hand in hand. And actually all these needs to be strengthened by new leadership style and also a big picture for the future, working with United Nations Sustainable Development Goals and 4E culture. 4E culture is empowering, enabling, and enacting an ecosystem mind-based culture. And not go into the details of transformational, resilient, and coaching leadership, but I will give you some hints. Actually, there are 7 strategic action points and 11 skills of these kind of leaders that makes them different from other leaders. While they are making strategic decisions, they always empathize with others, and they always drive for a compelling picture of the future that inspires others and also enables others to engage. And also they look for strategy developments and new trends in the fields that are present, but also they are entering. And skills are very important for these leaders. They are reinforced and driven mainly by certain values: compassion, empathy, and courage at the very top, and also positive mindset and high performance habits. And they are coachable and coach. What do we mean by that? It means that they are open mindsets. They are actually for growth and proactive mindset. Because if we think about CEOs or leaders or managers at the very top, mostly they may be very reluctant to digital formation or any kind of transformation. So coaching mindset enables the change and breaks that resistance or reluctance. And very shortly, coaching is about unlocking the potential of self first and then others, and then drawing or building a big picture around goals, values, and coaching culture. And this is very in alignment with what organizations are now going through in terms of building their organizational structure around purpose, value, culture, and in alignment with coaching mindset, goals, values, and culture. And actually, transformational coaching starts with coaching self and then coaching healthcare professionals. And actually, it has been shown also by research that coaching leaders or transformational coaching style enables job satisfaction and psychological well-being and increased performance among healthcare professionals. And when healthcare professionals coach patients as a domino effect, for example, in my research, I have shown that there is at least 6% reduction at 3 months glucose, hemoglobin A1C, 14% reduction at stress levels, significant improvement at lifestyles and self-management skills like eating healthy, exercising regularly, improved self-efficacy and self-esteem, and further improvement at emotional intelligence and resilience. And when patients are coached, they to coach their family members for positive behaviors and positive health outcomes, and families impact community, and then we go globally, and it affects achievement of sustainable development goals. And actually in 2020 July, United Nations Sustainable Development Goals platform has started a training on developing transformational partnerships to catalyze SDGs implementation to facilitate system transformation. So transformation is already on their agenda. So from there, we are going through sustainable proactive impact in health and wealth individuals to healthy societies. So as a summary, these leaders, I ask strategic questions like, what will the future look like? Where do we want to be in that future? Where are we now? What will be our strategic action points? What are our barriers? Who are our collaborators, partners? What kind of tools do we need? They ask all these strategic questions and enable their team members to ask these strategic questions. But how do they do that? And how do they succeed that? Actually, they walk in 3 shoes. They first walk in the shoes of a leader as a professional. They are very good communicators. They build very strong relations with their employees, stakeholders, and partners. And also they show the way through a compelling vision, but also they are very good at managing themselves in terms of, let's say, priority management, time management, stress management, being proactive rather than reactive. They have a growth mindset. And third pillar are inspirers, if we may call. They just inspire their teams for sustainability, and they work around big picture goals like sustainability development goals, and all that enables digital, emotional, and intelligence pillars, which enables transformational leadership. So I'm almost about to finalize my presentation, but all this I can say needs mindset training for leaders. That is a mindset training. That is a challenging training, but that is possible. And actually I'm working on that. And that is the way I see the future. So if possible, if we have time, I would like to ask, so what is your biggest takeaway from the session? And if you can go to www.menti.com and use this code, that will be great. So this is also in a way using digital technology in our platform, a mini case, if you don't mind.
Oh, okay.
If possible, if not, it's okay.
Yeah. Okay. Thank you very much, Dr. Çınar. Thank you very much for this important presentation. I'm sure they will answer it. Yeah.
Thank you.
Yeah.
So.
In your presentation, you mentioned that COVID-19 is pushing us to go into a digital transformation in health delivery, health services delivery right now, and coaching is important. And of course, many healthcare organizations right now are in the need of preparation for post-pandemic. We can take 2 or 3 questions regarding your presentation. If there is anyone like to ask a question, Dr. Çınar is ready to answer. Is there anyone like to ask a question? I have a question, Dr. Çınar, regarding digital transformation, especially in these corona times. You know, the healthcare delivery actually is a kind of activity you do face-to-face, and sometimes these face-to-face meetings, healthcare provider to patient provide some kind of placebo effect. So you get relieved at least 25 to 50% from your illness or disease because of this placebo effect. Do you think that this too much digitalization in healthcare can affect this, can prevent this placebo effect if you are a receiver, for example, or a service provider? I'd like to know the effect of placebo effect of this.
Yeah, thank you. That's a very interesting question. Thank you. Yeah, it can prevent that placebo effect, but also on the other hand, I have concerns is everything is digitalized, because humans are psychologically and connected to each other. So even it is digitally transformed. For example, we are working on interventions where, for example, coaches can coach the person one-to-one or in teams, because there are, yes, I know, the online coaching platforms, online digitalization, but it is not like real person in real time coaches you, because every person has unique challenges, every person has unique needs. So coaching through powerful questions enables tailored approach. So that is my observation, and by research I can say that we still need human engagement, one-to-one engagement in digital platforms.
Okay.
I don't know if I answered.
Right. Yeah. Thank you. Is there any question? Any person like to ask question or make a comment to Dr. Çınar? Thank you very much again, Dr. Çınar, for this wonderful presentation. If there is any question, they know your email. They can email you or ask you a question by communicating, electronically.
Thank you.
I'm sure.
Thank
Thank you very much again. Our second presenter in the plenary session 2 is Dr. Stopa Neogi, and she's the director of IIHMR. So, Dr. Neogi, the floor is yours.
So good afternoon, everyone. Good evening, everyone. Good morning to all of you who are from the other part of the world. And thank you, Chairperson, for giving me this opportunity. So what I'll do is, we have heard a lot about technology, digitalization, leadership, etc. So through this presentation of mine, I'll be taking you through the different steps and the ways by which India is trying to emerge as a leader in technology adaptation. So this is a case study which is based on the diagnostic methods for anemia in India. This we have done in collaboration with the government. We know that anemia is an important problem. It's a major public health challenge, and there are certain hemoglobinometers available which are quite outdated. Apart from this, there are several other devices available in the market, but the accuracy of those devices is questionable. That is why we were asked by the ministry to give them a simple answer as to which hemoglobinometer they should adopt as part of the national program. So for this reason, the time when we initiated this study was in 2013-14, when these devices were in the market. One is a hemoglobin color scale. The second one is a digital, which is true hemoglobinometer or true HB. The third is a non-invasive, another digital hemoglobinometer by the name of Touch HB. So these were the three devices which are available in the market. And then we were asked by the ministry as to which device is the best for the ministry or for the country as a whole. So the objective of the study was to assess the accuracy of these devices against the gold standard, which was automated autoanalyzers. And then this was designed as a prospective diagnostic accuracy study across 4 medical colleges of India. And the sample size calculated was 2,500 for each device. When we completed the study, we could clearly show that out of the 3 devices, the digital or the true hemoglobinometer, true HB, gave us the most accurate results, as you can see by comparing this with the other figures in terms of sensitivity, specificity, likelihood ratio, etc. Obviously, our conclusion was that true HB is the device which can be taken up by the national programs. But then there were several concerns raised by the ministry. And the concerns were that this study was done in medical colleges. Are you very confident about the external validity? In the medical colleges, the laboratory technicians were involved. Are you confident that the health workers of the ANMs, as we call in India, they can also perform equally well? How confident are you that the devices will work well in extremes of weather condition, where the temperature is around 0 degrees centigrade or even as high as 50 degrees centigrade? How confident are you that the devices will work well in field conditions and not in a laboratory setup? And how much is going to be the investment by the government? So these were the questions which are asked by the government to us based on the results which were submitted to the ministry. So in order to answer these questions, we submitted another proposal to the ministry, wherein we said that since the first phase of the study was done in the medical colleges, here instead of technicians, we will only use the health workers. Hence, only the best device which was assessed in the previous study would be taken up for the field level study in the next phase. When we submitted our proposal to the ministry, there was one more device which was actually submitted as a good device. So the ministry then had to choose between the 2 devices, and both of them were digital hemoglobinometers. So which device is better? So then they entrusted us with the responsibility to compare these 2 digital devices and tell them which is good for the country. And the request of this type, they are generally sent to the Department of Health Research, which is a kind of a body in the ministry to guide the ministry about the adaptation and adoption of different technology for the national programs. Hence, our proposal was shared with the Department of Health Research for funding. Now, the way DHR functions is that they generally have a stakeholders meeting where they call people who work in similar areas. So in that stakeholder meetings, all the manufacturers of the company or the devices, which generally they have devices for estimation of hemoglobin, all those manufacturers were invited in a common place. And then during that stakeholders meeting, we got to know that there were 2 more non-invasive devices which are there in the market. Hence, we were asked to compare all the 4 devices to guide the ministry as to which one is the best. So we had 2 digital hemoglobinometers, TrueHB and HemoQ, as invasive. Invasive means they require a drop of blood for estimation of hemoglobin. And there are certain non-invasive devices, Masimo's and Ageo, which were non-invasive devices. So all these 4 devices we were asked to compare. So again, the objective of this study was to assess the accuracy. Also, because the prime user for anemia detection is going to be the health workers, our job was to find out the level of agreement between the health workers and the technician. Again, to address the question whether it is equally effective in extremes of weather condition and the cost effectiveness of the device. So these were the requirements by the ministry in order to adopt the technology. Just to tell you the methodology in brief, this was the gold standard, the autoanalyzer. We had the first invasive device, second invasive device to be used by the health workers, then the same devices to be used by the technicians who are relatively more skilled, the non-invasive devices, the third and fourth devices, to be used by both the health workers and the technicians. And then we compared every device with the gold standard, which gave us the diagnostic accuracy of the devices. And then comparison between the levels of agreement between the technicians and the health workers, which gave us the level of agreement. So based on this framework, we initiated the study. And when we did it, we found that the 2 invasive digital hemoglobinometers, which is HemoQ and TrueHB, they performed better than the non-invasive devices. This was for detection of anemia, means anemia, yes or no. And anemia, according to ICMR guidelines, is hemoglobin less than 11. So based on this, we found that invasive is better than the non-invasive devices. However, between the 2, HemoQ fared better than the TrueHB. Now next, the requirement of the government was that it's not only important to diagnose anemia, our priority is severe anemia. So we want to know how accurate are these devices for detection of severe anemia. So when we did the subgroup analysis, we found that the results completely reversed, which means in the previous one, we saw HemoQ was performing better. Here we found that TrueHB was performing much, much better than HemoQ. This is the graphical representation. This shows the agreement between the autoanalyzer, the gold standard, and HemoQ for all levels of hemoglobin. This is for severe anemia. See how dispersed the values are. For TrueHB, again, the agreement is better. And for severe anemia, the dispersion is there, but not like HemoQ. So clearly, it emerges that TrueHB may be a better device for anemia. Then we also were asked that since HemoQ is also used in several surveys, by how much is the level of overestimation or underestimation? And here we calculated and showed that HemoQ actually overestimates severe anemia level by almost 1 unit. So we had all the kind of calculations done to show which one the government should take up as part of the national program. When we compared how these devices perform in extremes of weather conditions where the temperature was almost 0 degrees centigrade, we found that both the good devices were overestimating hemoglobin by almost 1 to 2 units, which was again a cause of concern. Then we also wanted to see that if the same device using the same sample at the same time is estimated by 2 equally qualified people, how much is the level of agreement? And we found that in this term, both HemoQ and TrueHB fared equally well. So there was no difference between the two. Another objective of ours was to find out the level of agreement between lab technician and A&M. And here again, we found that HemoQ was performing better than TrueHB. So when we tried to assimilate all the points, what did we find? We found that invasive devices showed better performance. For severe anemia, TrueHB fared better. But on the whole, both the devices overestimated hemoglobin in extremes of cold weather condition. So when we presented these findings to the ministry, they said that how much. Okay, so apart from the accuracy, they were interested in knowing other parameters which are extremely important before a technology is included in the national programs. Accuracy we have already seen. Beside the data storage, portability of the device means weight of the device. So will the health worker be comfortable carrying it in her purse? In terms of weight, in terms of dimension, ease of use. Ease and duration of training. How much will the country have to invest on training these people who are the ultimate users? Objectivity in the readings, because India is a huge country and so many health workers that are there. So the more objective the values are, the better it is. Convenience to the patient in terms of pain, in terms of happiness, or whatever you can consider convenience to the patient. Time to perform each test. Need for recalibration, because all these have implications on the economy and the finance. The wastage per test, operating temperature, the shelf life of the equipment, the storage conditions which are mandatory, the source of power in the facility and community, and the biomedical waste management, and last but not the least, the approvals. Is it approved by anybody? So all these parameters were actually very critically looked through to compare the two devices as to which device is the better one. Then another parameter which came up was the cost. Whether to do the costing or the cost effectiveness. So the ministry wanted to know from us how much will be the additional cost to the ministry if they adopt HemoQ or TrueHB. So based on the rates which are quoted by the manufacturers, we found that typically in a rural area for HemoQ, 24.4 rupees would have to be invested or spent for each test as compared to almost 39 rupees for a TrueHB. Now again, the confusion was whether to go for a device which is more accurate and more expensive, or a device which is cheaper and relatively less accurate. So when all these discussions were going on, the answer from the Department of Health Research was that if you have to choose a device, you can go for a device which is more accurate, provided the cost is not very high. Then a request was sent to the ministry whether they would be ready to spend 15 rupees extra to choose a device which is more accurate. And based on the recommendation, what was told to us was that here cost effectiveness is not required, because your main determining factor is accuracy. First comes accuracy and then comes other things. And more importantly, no market survey was done to assess the cost. The costs were based only on based on the quotes which are given to us by the manufacturers. And obviously, if it is purchased in bulk, then the rates might change. That is why, based on this, it was decided that TrueHB would be a better choice for inclusion in the national program as part of Anemia Mukt Bharat, or Anemia Free India as we call it. And hence a policy brief was prepared along with us by the HTA, which is Health Technology Assessment Department of DHR, and sent to the ministry for inclusion in the national program. Thank you. So this was just a small case study to let you know what factors you should keep in mind if you have to sell your technology to the government or to the private sector. That's all. Thank you.
Okay. Thank you very much, Dr. Naogi. This is very important presentation and technology adaptation in healthcare, and you try to give a good practical application of anemia case using different tools in here. But I see that in your presentation, the government officials are still paying attention to cost effectiveness of different intervention. It's not very costly actually. Sometimes cost effectiveness ratios doesn't mean that we cannot invest from the policy making point of view, because you are reaching to rural people more by using these approaches. This is very important, especially showing that you have the numbers and figures, evidence-based. We have we can take some questions, like we have 5 minutes more in your session. I'd like to, if you have any question, please raise your hand. Yeah, if you have any question. Okay, if there is no question, I'd like to thank you again for this important presentation. And I'd like to invite our final speaker in our session, and Dr. Venkatraman from Delhi University. Dr. Venkatraman is coming from another session. It's another parallel session. She asked me to be a third person in the presentation. And Dr. If I'm making mistake or mispronouncing your last name, please forgive me. I'd like to invite Dr. Venkatraman. The floor is yours now. Thank you.
Thank you, Professor Adnan. You pronounced my name very well, and
okay.
I'm very happy that you accommodated my request to be the last speaker. Thank you so much.
My pleasure.
And good morning, good afternoon, good evening to people who are from different parts of the world who have joined this session. And this is a wonderful conference, and I should thank the IIHMR for giving me an opportunity to speak on a subject that is still evolving, and we still are learning something about how do we regulate and govern the digital health space in Indian context. So my discussion, or I don't have a presentation, but I would be speaking more or less extempo about a few points on regulatory and governance issues in digital health space in India. I'm sure many people who had listened to the last session would have known about the digital health, what does it cover. But just to set the tone for the session as such, I thought I'll just mention some of the background details before getting into the specifics. Digital health market in India, according to one estimate, was about $116 billion in 2018, and is expected to grow to more than about $450 billion by 2024. This is specific to Indian context. So that's the kind of value that the digital health space brings to Indian health scenario. So what does digital health technology cover? We have telehealth and telemedicine as one part, mobile apps or mHealth apps, that's another part, remote diagnostics, robotics, wearables, the ones that we wear for monitoring our own activities, e-commerce, particularly pharmacies, electronic health records, health information systems, bioinformatics and medical analytics, 3D printing, and digital epidemiology. And more things are coming almost every quarter that you read more about this. These are broadly under 4 categories. One is devices, second is informatics, third is e-commerce, and the last one is service delivery platforms. For example, telehealth qualifies as a service delivery platform. We all know that digital health is the benefits of digital health technologies. It's supposed to improve the cost efficiency or cost effectiveness. It's supposed to make things much easier to access, and it has a better reach despite the digital divide that we talk about. And still, it is considered to be one of the platforms that's going to be future. During the pandemic, the digital health technologies have demonstrated its utility. During COVID-19 pandemic, telehealth, mobile apps, and e-pharmacies were used extensively, not only in India, but in many parts of the world. But the rapid expansion of digital health is not just about reflection of advancement in medical technologies and tools, but also it highlights some of the inefficiencies in the prevailing health system. When we talk about existing health system, including the gaps in regulation and governance. Just about the last speaker, Professor Niyogi, mentioned about the appropriate anemic meter, or a technology that detects anemia. And there are two equipment or two tools two devices that she seemed to have tested. And one device seemed to be highly not calibrated at all, or validated, standardized. So the government should be thinking about adopting one such kind of a anemic meter for their national program, but simultaneously go after another device which was showing wrong results all the time. Now, can you imagine, on the one side, the public sector assumes that they would like to have a standardized tool, whereas patients who are using another tool or another device need not necessarily be bothered by much. That's wrong. That's where the regulatory failure, that's where the governance failure comes in. As such, in Indian context, the regulation and governance is much more to be desired. So there is a lot more gap that we have in the regulation of health services, leave alone the technology space. Having said that, regulatory and governance issues in digital health arena is a complicated matter. I plan to highlight only some of them, not all of them, and therefore some part of my discussion will not cover as a large space of digital health as one can imagine. Let's start with the personal touch part, or the trust part on technology. Is there a trust among the physicians or the providers, and between the provider and the users, in the usage of technologies? If the technology is the only way that patients can avail services, perhaps we don't require physicians anymore. You can program everything in a machine, and the patient has to just go there and talk to the machine and perhaps get a prognosis or a diagnosis and perhaps get prescription too. But that's not the case. That's not going to be the case. And therefore, we will have to think about the trust element between the technology and the provider and the patient, of course. But most technologies are developed from techno-commercial angle by either startups or by technology firms, sometimes with or without a user interface. But such inventions do not necessarily look at the social or legal or health outcome angle. For example, somebody mentioned to me a couple of weeks ago in one of the artificial intelligence discussion. Apparently, in any of the artificial intelligence community, they do not have a sociologist or an anthropologist. Now, the digital or the artificial intelligence is going to rule the roost in the next decade or more, or rather future of the humankind. And we don't know what kind of informatics that the society is going to be subjected to, and what is the likely impact these informatics is going to have or play a role in our day-to-day life. So without such kind of inputs from interdisciplinary subject matters, it's not going to be easy to predict the potential impact of technologies in the long run in our life as well as in the societal sphere. This highlights the need to bring the inventors, the patients, physicians, the providers, legal experts, and public health professionals together while developing digital health platforms. So it's important for all of us as a public health domain experts to really think through about the likely impact of digital health technologies on the health outcomes and the public health at large. The second area, or the next area that I would like to think about or discuss, is about licensing and standards and the regulation of digital health devices. Just Professor Niyogi's presentation just highlighted that part. So digital health devices market is highly fragmented. It ranges from self-monitoring wearables like my watch to teleradiology and triage technologies using artificial intelligence. But who licenses such devices? Electronic devices are licensed by CE, but its health applications, who standardizes it? Who determines its efficacy, the quality? How clinical outcomes are reviewed, tracked, and clinically approved? Who provides the oversight? Is there any legal policy or a legal or institutional framework to monitor such kind of health devices or health technology devices? Is it FDA in the US context, or is it MITI in Indian context, or it is Bureau of Indian Standards, or is it drug controller, or is it the health system research at the Department of Health Research? Who is supposed to be really giving the approval? For example, during the COVID pandemic, there was a plethora of oximeters available. So you could just go to any e-commerce portal, you can buy any oximeter. Nobody knows whether these are standardized. Nobody knows whether they were calibrated properly. So you could actually end up having something that is wrong information. For example, my own iPhone and my wearable, I have a watch, shows different number of steps when I would take a walk. Which one do I believe in? Where is the standardization that needs to be brought in, especially when it goes to market and when it actually tells people different kind of data pieces? How should these products be licensed and monitored? This raises the question to whether our regulatory framework, especially in Indian context, is adequate. Right now, medical devices are licensed and standardized or approved by Drugs and Cosmetics Act of 1940, but they have brought in something called a medical devices rule in 2018. But almost every quarter, you have a new medical device introduced in the market. So you need to be keeping up to the new products that are launched in the market. Let's go to the next issue, which is about telehealth. India has a national telehealth consultation portal. In fact, two of them. One is eSanjeevani, the other one is ORS. eSanjeevani particularly, which was launched in 2019 November, has already logged in more than 70,000 hours of patient consultation. And it has the potential to reach all corners of the country. It requires to be converted into language-specific, context-specific interface. But remember, telemedicine, telehealth consultation in India was illegal till April 2020. And yet, it had been years that telemedicine was being practiced by hospitals and medical professionals. So how far do we lag behind in regulating something that is widely practiced? This is a question that we need to ask ourselves. Another sensitive area is about information system, especially on patient monitoring, patient-related information and its analytics. There's a large volume of data is getting gathered leading to data security, privacy, leakage, fraud, and thus there is a great deal of problem of trust in such technologies. For example, in India, we launched during the pandemic, we launched what is called Arogya Setu. It created a mobile application which is useful for people to know what is their own health status or what is their neighbor's health status in terms of COVID. But there are a lot of resistance about how this data would be used, who is going to use it, etc., etc. But remember, real-time data usage can be very, very useful. Recently, I was reading an article that appeared, which talked about how artificial intelligence tool can help data triage to, in the case of TB, using chest X-rays and also recording of chest noise during coughing among the TB patients, which can improve the accuracy of TB diagnosis. But these are some, what we call it as patented technology, and therefore open source technologies are very less in this digital health area. Although the private sector dominates the digital health space, Government of India recently launched a national digital health mission, which was in August 2020. Under this mission, a digital infrastructure comprising health ID, including treatment history of a patient, DigiDoctor, a repository of doctors practicing medicines, health facility registry is supposed to be incorporated. The National Digital Health Mission promises a great deal, but we still have a long way to go for a state level or a country-wide adoption of digital health system in the public health system or public health sector. The reason for me to say so is that we still do not have a standardized electronic medical records, either EMR, EHR, or public health information system. Government has several initiatives like e-Aushadhi, for example. Some of the people who are Indian audience would understand this. CoWIN, for example, recently an integrated model, platform for vaccination. Nikshay for TB patient. E-Shushrut for child and reproductive and child health. Arogya Setu for COVID care. E-Rakt Kosh for blood bank related stuff. E-Sanjeevani for OPD consultation, ORS for telehealth consultation. But these systems do not talk to one another. For example, E-Sanjeevani and ORS has similar purpose, but one was developed by CDAC, a government department. Another was developed by NIC, another government department. They don't compile the information together. We still are in search of a patient information system on any particular disease. Similarly, there is another program called Mira Hospital and e-Hospital. Both are under the Government of India and both do not speak to one another. Just compare this with Malaysia, where National Health Information Exchange combines a large number of such kind of a modular options, so that you have one single repository for all kinds of information. In India, again, Ayushman Bharat is one of the largest repository of patient-related health information system in the country. But we still do not use the data from the Ayushman Bharat for decision support, such as quick claims settlement, clinical audits or forensics. So these are something that we still do not use the data for. Okay, I don't get any signal, so I assume that all of you are not happy about me continuing. So let me try to complete it.
I'm guessing we lost Adnan again.
Okay, all right. So I have 2 more minutes, I hope. Deepti, you are the one who is going to be giving the word of thanks, I guess. So you allow me 2 more minutes, I hope.
Please, sure, sir. Carry on.
Okay, this is about the next information. It's information about the private sector. We know that a large proportion of India's population go to the private sector, and the private sector do not have any kind of accountability related to the kind of information that they are supposed to share with the government. So within the private hospital itself, there's a lot more leakage that happens. Because most of the private hospitals are hospitals of a small to a large size. They buy, what we call it as patient information or hospital information system off the shelf from some, IT companies. As a result, many of these hospitals do not have a standardized format. Besides that, a lot of this information that you store it in the cloud, they are stored, most of the servers are outside the country. How do you ensure data security in such kind of places? I'm told that most of the leaked information about patients happens from such hospitals, because these hospitals interchangeably use email system with electronic medical records and are often subjected to spam and other malware. So we don't realize that often the search engines, the credit cards, the message platforms, e-commerce portals have more data about our health conditions than even our own doctors. How do we regulate the usage behavior or technology service platforms which actually combines or compiles such information and perhaps not regulate it properly or keep it in a certain kind of integrity, data integrity? We know that a lot of doctors are already fed up with the people coming with the Google. I mean, they went to the Google, searched about their symptoms and found their disease is so and so, and they need to be treated with this particular manner. I'm sure many doctors are already fed up with that kind of information from Wikipedia and Google and all that stuff. For example, you go to any of the website, you will find COVID prevention immunoboosters. All right? Who is regulating this information? Who is actually providing oversight for this? The next issue comes is about e-pharmacy business. I think during the pandemic, e-pharmacy business has been a great deal of upsurge. So my final point is that digital health is not, or digital health technology is not a silver bullet for all that which is troubling the health system. We still need a very strong service delivery capacity, both in the public sector and the private sector, and they need to speak to one another. But adoption of digital health technology is inevitable. But adoption of digital health technology will require rapid, or at least a radical, restructuring and reorganization of the conventional health service delivery model. And therefore, integrating the digital health technologies to improve the access or equity or affordability, etc., needs a legal, regulatory, and oversight mechanisms and governance structures. That's where I stop. Thank you so much.
Thank you very much, Professor Venkatraman. You really mentioned really important points, but two things that it really took my attention. One of them is the interdisciplinary approach for the digital health, because too much digitalization, we don't know the results, what will happen in our life. So I agree with you, sociologists and anthropologists and different social scientists also should be a part of this important team, because otherwise the technique people always think from the technical part. So I also agree with you, there is a kind of standardization and also cooperation among the institutions, but still the good example that you gave, especially in the corona time, about the oximeters, you really pay very important, you took our attention to a very important topic right now. But again, I agree with you that there should be some kind of boundaries and also regulations for this, but still a kind of international cooperation is needed. So some important institution like WHO or other type of strong international organizations should take care of this part, important part. Thank you so much for this important presentation. I learned a lot, and I learned other presenters' presentations a lot. Thank you so much. I like
Is it okay to ask, Adnan, is it okay to ask a question or two?
Two questions I think will be good. Otherwise, we will stay until morning.
Well,
Yeah,
for us,
please.
it is no problem at all. Our day is starting. We have been up since early in the morning.
Okay, please.
Well,
question?
Professor Venkataraman, first of all, that was fantastic information that you gave. I was really surprised when you said that it was illegal to provide telemedicine, because I remember, and that was just approved, you said, right? Last year in 2020, I brought a group of students who are study abroad to India from US in 2014. So we went to the hospital, Narayana Hrudayala Hospital in Bangalore, and they had a setup over there in their hospital for telemedicine.
Yes.
And when you tell that it's illegal, that kind of raises a new ethical dilemma. How can they have a whole setup when it was illegal? So I think, and I'm going to give you another perspective over there, why I'm very excited with this information. I do a lot on ethics related issues, and that's a pretty big ethical dilemma over there. Adnan and Dave Wyeth, I see him over there also logged in. They are on my editorial board. We'll talk about the Meet the Editors panel on day after tomorrow. My journal is Hospital Topics. It's the oldest in healthcare administration. It'll be a 100-year-old journal next year. So so I'm the editor-in-chief of that journal. This is type of information that we may need to talk about. I like to see articles, something similar to that, which will bring some ethical dilemmas of what was happening, because I'm absolutely certain people in other parts of the country don't know that. PGI Chandigarh, they have a telemedicine setup because I went to their facility. In Mumbai at Global Hospital, they frequently interacted with people abroad. Of course, Narayana Hrudayala is a Joint Commission International accredited hospital, which has a telemedicine setup, but based on the information, they were involved in, let's say, illegal activities. That doesn't sound real good enough. But I think telemedicine is fantastic. And I will give a shout out to Dr. S.D. Gupta and Professor Sudhani over there at IIHMR, because I wrote an article related to telemedicine 20 years ago, and they published it in their journal, Journal of Health Management. 20 years ago, I was talking about telemedicine when people were not even thinking about it. So maybe there is some value now. And COVID definitely has brought out the value of telemedicine. So I really commend the information you brought and all the panelists. This was a fantastic session. I can see a whole bunch of my students signed in. So I would love for you all to chime in and say, how do we deal with this thing now? And you find out about this ethical dilemma.
Well, I studied Narayana Hrudayalaya, and one of the district hospitals that they were providing telehealth, telecardiology services way back in 2004. And I wrote it in my public-private partnership, one of the case studies on that. But when I was reading about telemedicine, I realized that there was no law till 2020, and it was within court. This was a wink and nod kind of a thing as to it is, it's good for the society, so but don't ban it because you don't call it as illegal. Similarly, today there are a lot of e-pharmacies, but there are no acts related to e-pharmacy. For example, you can have an electronic, a prescription, but electronic prescription is between the doctor and the patient, but there are no, within court, legal provisions to allow e-prescriptions today. So it's a kind of an evolving debate. It's a kind of an evolving debate.
It's even more interesting in the US that with telemedicine, you can provide all the consultation in the state that you are licensed to practice. But a fantastic doctor cannot provide consultation to somebody in Alaska, even though it's still in the United States. That's a problem. But providing consultation to somebody in India, that's not, because there is nothing like that of interstate rule involved in there. It's very interesting like that.
Dr. Sharma is gonna make a kind of conclusion. It says vote of thanks in here. But before I say goodbye to my colleagues, I would like to thank Dr. Sodani, Dr. Gupta, Dr. Tripathi, and all organizers of this conference, and all participants from all around the world. This very important conference. I will try to join the other sessions as well. Also, I would like to thank my Indian brother, Professor Ashish Chandra from Oslo to over there. And he's my, not biologic, but real, more than kind of biologic, not biologic, but real brother. We have known each other more than 20 years. So have a good evening to everyone, and have a good day to everyone. And thank you very much again for this opportunity. Yeah.
It's a pleasure. Thank you.
Thank you, Dr. Kisa, for leading the session and sharing your profound knowledge with us. And I thank the eminent speakers for giving your insights on the topic leading the change for technology adaptation in healthcare. The session was full of valuable information, and I'm sure that my colleagues attending this session would agree to it. Moving forward, I would like to invite Dr. Deepti Sharma, Associate Professor, IIHMR University, Jaipur, to extend the vote of thanks on the plenary session too. Over to you, ma'am.
Thank you, Urvashi. It has been a very rich discussion and thought-provoking session. Thank you all. Let me have the privilege to present vote of thanks for the plenary session second, leading the change for the technology adaptation in healthcare. My sincere thanks to the session chair, Dr. Adnan Kisa from Norway, for sharing his valuable time and gracious presence. Thank you, sir. I would also like to thank Professor A. Venkataraman for the valuable thoughts he has shared on digital health technology and gap in regulation of the health services. Thank you, sir. My heartfelt thanks to Dr. Stupa Bandyopadhyay Niyogi for sharing the insights on the adaptation of the various devices on technology by comparing on the various parameters and reaching to diagnostic accuracy of the device. Thank you, ma'am. I would also like to convey gratitude to Mr. I.C. Visak Sinar for the invaluable contribution in the session. Your insights are really helpful when you talk about changing the mindset of the leaders. Then only you can bring the transformation that is really very inspiring and very knowledge-worthy. Thank you, ma'am. Let me express my gratitude to Urvashi for anchoring. IT team, marketing team, my colleagues, staff members, and attendees for the active participation and making the session a successful one. Thank you. Thank you, Dr. Ashish Chandra, too, for such a genuine question on ethics. Thank you all. This is the end for day one of Pradanya conference. So thank you all. Good day.